Good morning and good evening, fellow doctors and colleagues. For today, Dr. Sheng-Po retirement virtual webinar. We're honored to introduce Professor Zhongsan Mingren as our invited speaker. Professor Zhongsan Mingren was born in Pingdong, and he is now the department head of Department of Otolaryngology, Yokosuka Hyosen Hospital. Professor Zhongsan Mingren was graduated from Kitasato University School of Medicine. He finished his research fellowship in University of Wisconsin Medicine and Armed Force Institute of Pathology in USA. And he also completed his visiting fellowship in University of Pennsylvania, Philadelphia, USA, and University of Paris and the University of Lyon, France. And he received his PhD in Kitasato University in 1994. His area of special interest includes minimal invasive surgery of head and neck disease, functional organ preservation of laryngeal cancer, subarachnoid partial laryngectomy, transoral laryngectomy of hypopharyngeal cancer, management of oral and laryngopharyngeal disease. Today, Professor Zhongsan Mingren's presenting topic is minimal invasive open laryngopharyngeal surgeries. Please give a round of applause to welcome Professor Zhongsan Mingren.
Okay. Good morning, everybody. Can you see the slide?
Yes. Yes.
Let me start my lecture. Thank you, Professor Ko, and thank you, Peter, for inviting. Thank you for allowing me to be part of this honorable webinar. Okay. Before I start my webinar, I would like to recognize my father, Shotaro Nakayama, Chinese name Jiang Zongsan. He was born. Can you see my father's slide?
Yes.
Okay. I have a secretary, my son is better than today is holiday in Japan, so I'm at home. So my son is taking care of me. So before I start my webinar, I would like to recognize my father, Shotaro Nakayama, Chinese name Jiang Zongsan, born in Gongsan. Without him, I won't be here. He is 92-year-old and a rhinologist. Did so many outpatient nasal surgeries. Upon my request, he jotted this memo on the right lower, describing his secret surgical ingredient to me. It is my pleasure. It is my treasure. Thus, he has passed his golden button to me. Can you see the next slide?
Yes.
Okay. Though I am specializing in head and neck surgery, I still do septoplasty and turbinoplasty every week for about 100 cases a year. Rhinology surgeries include the most basic techniques in ENT surgeries, and I cherish this surgery very much. Congratulations, Peter. Your warm heart has inspired so many colleagues and persons, including my children. This slide shows the age distribution of head and neck patients at their initial visit. In the past 50 years, the average age gained almost 20 years. Aging in head and neck patients has become an imminent issue worldwide. Searching for sustainable head and neck management, such as minimally invasive surgery, MIS, is imperative. MIS is not that we ought to do something special. This child with pyogenic granuloma has been treated with a 2O silk tied to the stem of the lesion. And after 2 interventions at clinic, he is a happy kid, ready to go home. This is a 78-year-old man with T2 bowel cancer associated with poor general conditions. The tumor was removed and the wound closed by a buccal fat pad. This is also a good example for MIS. I think, Peter, you are the specialist for this fat pad. A long and winding orifice can also be a double-edged sword. Hinders easy access to the laryngopharynx. Nonetheless, various transoral MIS approaches have been innovated and incorporated into the front line. Open approach, generally considered as having greater invasiveness, can also be sophisticated by good hands. Like this lateral branchial cyst, surrounded by vital organs, can be removed with MIS manner. This is a 94-year-old woman with T4 lower gingival cancer and severe dementia. Her son pleaded to us for the surgery because of her excessive pain, and she was shouting every night at home. We did the mandibulectomy within 3 hours and removed all catheters by day 1. And she resumed diet from day 3 and was discharged at day 9. This is the port of Yokohama from yesterday. Peter, please come to visit again. We are waiting for you. The kids are waiting for you. On the second half of my talk, I would like to focus on my signature surgery, supracoacoid partial laryngectomy, SCPL. According to the US SEER database, laryngeal cancer is the only site showing survival deterioration. Both local recurrences and late toxicities on the result of over-indicated chemoradiation therapy are considered responsible. Since laryngeal cancer is still not a fading disease, we cannot pass these unfavorable legacies to the next generation. Let me show you two typical cases. This is a 61-year-old man with right glottic cancer. The cancer invaded right vocal cord and the paraglottic space and was staged as T2. He was chemo-radiated, but 3 years later, the cancer recurred from the core of cartilage erosion. In fact, this case was with paraglottic space invasion should have been staged as T3. Fortunately, his laryngeal function was salvaged by SCPL. But in reality, most of the radiation-failed patients have to go for TL, total laryngectomy, and in addition, suffering from wound healings. Late toxicity is famous in literature, but rarely encountered. This 71-year-old supraglottic case received CLT and neck dissection 15 years ago. Last year, he came to us with 1 month history of hoarseness and dysphagia. He then developed difficulty of breathing and received emergency tracheotomy. Complete paralysis of recurrent and glossopharyngeal nerves was observed. He had so-called frozen larynx. In otology patients, 26% was reported to have severe late toxicities. This is the most recent NCCN guideline for advanced glottic cancer. We need to have a full spec of knowledge and capability as how to select right option for the right patient. If wrong option is selected, patient's life can be affected. For example, these cases. Many may think CLT can be indicated. However, with cancer embedded to cartilage, they are staged as T3 or more and are considered CLT resistant and the contraindication to CLT. Open SCPL, however, is also not invincible. In the era of minimally invasive surgery, led by laparoscopic innovations, there has been increasing accusations toward the invasive nature of classical open SCPL. Without exception, head and neck surgery has to evolve. Stanford University and we had conducted preclinical labs to minimize the invasiveness of SCPL. Please refer to the published article. We proposed to minimize the skin incision to 6 centimeters at the level of corticothyroid membrane. Six-centimeter SCPL was clinically introduced in January 2019 in Japan. The postoperative edema and the recovery of 6-centimeter SCPL was twice faster compared with 20-centimeter incision classical open SCPL. on the left. The extent of surgical scars were also significantly different, presumably reflecting smaller biophysical stress to the neck. Let me show you two extreme cases who desire for larynx preservation. Left is a 72-year-old T3 patient who have previously received 2 video-assisted thoracic surgeries, VATS, and radiation therapy to his lung cancers. Right is a 80-year-old T3 patient who had a severe emphysema, both with borderline pulmonary conditions. The patients returned to their regular lives 30 and 50 days after narrow field 6 centimeter SCPL. I probably did not indicate SCPL if I could only offer 20 centimeter classical open approach. These patients suggested that minimally invasive approach may also be beneficial for elderly patients. Facing survival deterioration, new generation US surgeons are evolving. Professor Schindler from Portland, Oregon, lately reported the decreasing use of CLT and increasing use of open partial laryngectomy and transoral surgery in their institute. Recent US review article also reconfirmed excellent potentials of SCPL. The pendulum has gradually swung back to the surgery. Loma Linda University in LA has been implementing surgical course every year, teaching SCPL to the next generation US residents and fellows. They are the key for resurrection in this field. Larynx preservation for hypopharyngeal cancer is another important topic. Because of the time restriction, I will not go too much detail to this surgery. However, this supracoacoid hemilaryngopharyngeectomy is a very nice surgery, simple surgery invented by Henri Lacroix, the father of Olivier Lacroix from University of Paris. And because of the different cancer character of hypopharyngeal cancer, special attentions need to be paid. For example, how to indicate the patients and how to operate the patients. But actually, on the right is 6 months after the surgery. This lady was really happy about that she can talk and that she can eat was before. He, after chemoradiation recurrence, she completely refused total laryngectomy that she said she will go to die. She has to lose her voice box. So in our daily practice, we have those patients that they just cannot tolerate total laryngectomy, total laryngopharyngeectomy. So I think we need to keep, although the cases are very limited, we need to keep kind of passing the baton of this type of surgery to our next generations. When larynx is saved, life can be different. This 61-year-old Japanese man with T3 cancer received SCPL 4 years ago, and he is currently working as a chief engineer building a new airport in Nadia, India. He sent this picture to me. He said, although it's a very dusty and noisy environment he is working, his voice just does not irritate him, and he can actually do his job and with a great pleasure. This junior high mathematics teacher is a 10-year survivor from salvage SCPL to his radiation fail, T4 cancer. He is currently teaching karate around the world. His tumor actually invaded after radiation recurred and invaded, breaking through thyroid cartilage and invaded strap muscles. It was a pretty ugly lesion, but yes, supracoacoid saved his larynx, and he just be able to continue his job as teaching mathematics teacher. And he told me, I won't be here if I had a total laryngectomy. So Peter, soon you and I will pass our golden buttons to the youngsters. I believe they have already gained so much from you and will serve their patients based on your spirit. Let us enjoy our second lives and wish you and your family much happiness and good health. Thank you very much.
Thank you, Professor Dongtan Mingren. Now we open to the floor for discussion. Is there any questions or discussions?
We have some dogs attending.
Yes, that's my dog. Sorry.
Is there any question or comments?
Hello. Good morning, Professor Meijin.
Hi.
Hi, Peter Burt. Yes. Good morning.
To see you. Good to see you.
Yes. Hi, Peter.
Very
Yes.
good.
It's my great honors, and I always learn when attending your wonderful lectures and very inspiring. And I appreciate how much you save the life of the patients that back to their normal life. I think it's very important, and it's very true that the momentum is swing back to the surgery. I'm glad to hear that. And I believe that the conservation laryngectomy is very important, that the new generation need to learn, and we also relearn what we maybe forget for some time. Yeah, I like the idea of the narrow field of the minimal invasive approach, and with your extensive experience and could you like summarize as a key success that make this procedure successful? Yeah, because we sometimes have a difficulty in preserving the function or even determining the extent of the surgery to balance between the keeping the function, also the oncologic results.
Thank you, Professor. Thank you. Last year, we had a good time in Bangkok at the Ashino. I will see you this November in Kaohsiung.
Wow.
We did.
Wonderful.
Yeah, it's a pleasure. But anyway, to do this type of special surgery, I guess to be simple, you just need to be eagerness is very important. And there are three parts. One is how to indicate the right patient. Of course, we know chemoradiation is a good method to treat laryngeal cancers, but you need to know what type of cancer that's contraindicated to chemoradiation to choose the right patient. And the surgical technique. Surgical technique is actually maybe the easiest part of among these three. You just need to learn from the expert. I will be happy to go to Thailand and teach the youngsters. If you can do total laryngectomy, once you see supracoacoid, you can understand and you can actually repeat it because every head and neck surgeons already know the anatomy. So you just need to know the clue and the points that teaching by the expert. Do not do the surgery just by reading the paper. This is wrong. This is, I think it's the textbook cannot fully kind of transfer the all clues. There are some clues that's analog. That's analog that you have to be there and to be taught by the expert directly. And the most important is post-operative surgery care and the follow-up of the patients. And you need to keep the eagerness and actually not to be arrogant. You have to be very modest because we are dealing with the cancers. Cancers are often that can sneak through our attentions. And so to be very modest manner and to be sincere to your patients and keep the eagerness is very important.
Thank you very much. That's very comprehensive answer. And looking forward to learn hands-on from you sometimes in the future. Yes.
Please say hello to your wife.
Thank you. Yes, absolutely.
Is there any more questions or comments? Yeah, I guess, patient selection is selected, just like Meiji, you said, select the right patient for the right surgery is very important. And I think the patient selection is especially difficult after chemoradiation therapy. I just wonder how would you decide, what's the key point for you? What kinds of image modalities you choose to detect the extent of the tumor? You use MRI or you use CT scan, and what's the key points to? Because it seems to me not every case, after chemoradiation therapy would be a very good indication for supracricoid partial laryngectomy. In my hands, it could be. I never did that before. Yeah, I love total laryngectomy, and it's just very difficult persuade me to select a good patient for, especially you consider the postoperative function. So what's the what kind you use CT or use MRI and
Yes, I think mainly CT, hopefully targeted CT, laryngopharyngeal space, targeted CT should be sufficient. Actually, we have the technique to observe the patients through fibroscope, and fibroscope image is probably the most important. That you repeatedly see the patients maybe every week, every month, and or every 2 months, and just keep the previous image in your mind and compare it with the next visit image, and also the complaint of the patients. Mainly the hoarseness is very important. That even though if you think the image is similar, but if the patient complain of the hoarseness getting worse, we should do CAT scan. Not necessary. MRI is okay, but not necessary, not the requirement. And if you really doubt about the recurrence, PET scan can also be done. But the most important is the close observation to the patients. And nowadays, I just finished my actually test, renew test to our kind of cancer society specialist. And nowadays, Japanese Cancer Society, they officially announced not to do too many CT scans during the follow-up examinations, because you can expose the patients with radiation. And so recently I rarely do CAT scan during the follow-up, and if I do, I rarely use enhancement. Actually the simple just the CAT scan image, because of the quality of the CAT scan is getting better. So not necessary to use the enhancement solution. But if you have received enhancement CT scan, you know how invasive that can be. And recently, this is a very new, I think, concept that the Cancer Society in Japan, they said, officially announced that not necessarily you need to enhance the lesion, unless you want, of course, for the primary surgery evaluation, it's very important, but not necessary for the follow-up evaluation. You can just do this simple CT scan, and that can be done in 5 minutes, and you can see the result immediately.
Thank you. And I do have one more question in regard to the postoperative care, because I believe a very good primary toilet would be important for the patient to have to undergo partial pharyngeal laryngectomy. But it's very really unbelievable for me that you operate on 92 years old patient with previous lung cancer, and also another patient with lung emphysematous. So my question would be, is there any test, especially for example, the primary function test, the spirometry, for you have to do that for every patient if they pass, and you will do partial pharyngeal laryngectomy, or And is there any special key for the post-operative rehabilitation?
Well, no, not really. Before the surgery, of course, you need to evaluate the lung primary function. But for laryngeal cancer patients, nobody has a normal primary function, of course. And you will, if you do the examination, you get the results that's moderate degree, borderline degree primary function. One test that I think important is the blood gas test in the room air. Hopefully that the patient will be able to have the result above 70 toes. 70, yeah. Of course, normal is 100. Better is 80, but the lower limit I set is like 70 in the room air, and plus the patient can climb up the stairs at the train station that without problem. And of course, for these patients, borderline patients or elderly patients with limited borderline primary conditions, we need to persuade them to have total laryngectomy, because we have to be fair to explain in the society, head and neck society, worldwide, total laryngectomy is the primary and primary treatment for your disease. But there are nowadays, because of the patient's wish is sometimes very strong, they will refuse to say that, because I just cannot lose my voice. That if I had a total laryngectomy, I may refuse. For those patients that I guess we will explain the limitation of the supracoicoid, and then if they agree to have it, that to be very careful about the post-operative cares.
Thank you. Is there any more questions?
Prof. Peter?
Yes, Marinda. Yes.
Yeah, good morning, Prof. Peter. So thank you. Sorry, I did not open my video. So good morning, Prof. Peter. Thank you. Always I attend some mostly your lectures, but it's really nice and very valuable. So good morning, Prof. Nakayama. So I have a questions. Some of questions already asked by you, Prof. Peter, about the age. Are there any limitations? Because you know that the age, biologic age and the real age is not the same. But sometimes we are afraid of doing the surgery for the older ages. But the other is, as we know that mostly the patients will choose the chemoradiations for to treat this cancer. But I also read that the partial laryngectomy can be done for the early stage. Do you have any consideration, Prof. Nakayama, beside that, which case that better to do the radiation? Because we know that if there is a recurrence in the chemoradiations, but we also can be done the surgery as well. So do you have any consideration for this, whether we can choose this better for the chemoradiations, or we can choose better for the partial laryngectomy? Thank you, Prof. Nakayama.
Good to hear from you, Marinda. I think we had a very good time in past Ashino in Bangkok.
Thank you, Prof.
Yes. Thank you for your question. Actually, for the in terms of the age, when I did the classical 20 centimeter supracoicoid, I limited the upper age to 70s. So the patients who above 70s, I did not kind of recommend supracoicoid because I knew the invasiveness of this classical surgery, and but after I incorporated the 6 centimeter minimally invasive supracoicoid, I can feel the very limited invasiveness of this surgery, and the recovery and the complication are very fast. Complications are very limited. So as I show you in the case, the maximum age of the patient is 80. So nowadays, the laryngeal cancer patients comes to the clinic. Most of them are above 70s. So lately, I think I did not have a case that I refused to do supracoicoid because of their ages. But for the patients above 80-year-old, like nearly 90, I don't think they are the case can be indicated. So for the patients with CLT, I have a very good example is the top institute in Italy. This is the institute probably most aggressively doing supracoicoid in the world. And I was invited to stay with them for 1 week, and they actually do not do chemoradiation at all to all the patients, laryngeal cancer patients. This is of course, is a very extreme case, and I think for the T1, T2, T3, T4, they do supracoicoid. So they have like 300 cases a year, and the surgeons come all over the Europe to learn this surgery. Actually, the extensive classical supracoicoid that I showed in my presentation is from their surgery. But I don't think that's the case, well-balanced indication. I think T1 should be treated with radiation alone, or like T1B with chemo, probably TS1 type of outpatient perioral chemo agent. And for T2, everyone think T2 is T2. No, T2 has a variety of phases. And if you have early T2, small T2, you can do chemoradiation with cisplatin. And for the big T2, is almost what in the US they call unfavorable T2. I think we can explain about the possibility of supracoicoid along with CLT to the patients, and explain the advantage and the disadvantage of both surgeries, and let the patients to choose. For the T3 patients, I usually recommend supracoicoid because we know in the literature the CLT result for T3 is somehow around 50 or 60% cure rate, which is quite different from supracoicoid, which is like over 90% control rate. So Is that did I answer your question?
Yes, thank you so much. Thank you very much, Prof. Nakayama. Thank you, Prof. Sheng-Po.
All right. Yeah, I'm happy to hear that. I guess it's Professor Spriano, right? In Italy.
Spriano and actually, yes, risotto. Spriano is still not a very radical. Spriano is from Rome.
Yes.
And this Professor Risotto, and I think his young successor already, Andy Bertolini. This is a hospital in Vittorio Veneto, maybe 30 minutes to the north from Venezia.
Yeah,
and it's a hospital in the rural city, but they are this kind of center of the open partial in the Europe right now.
Yeah, a lot of visits when I really do have. So thank you so much, Professor Nakayama, for your wonderful lecture, and of course, thank you for the participant. I believe Professor Meiji Nakayama really gave us a very good lecture on the indication and also some of the surgery technique, and then also most importantly, the patient selection and the post-operative care. Very good, demonstration and very good lecture. And so we really believe in your philosophy, and congratulations, especially to your father, beloved father, Jiang Zhongshan, which I think he would be very, very proud of you. You are the honor of all, Taiwanese fellows. And so we are very proud of you as well. And thank you for, contributing your lecture to my webinar. And so thank you very much. And for all the participants, thank you for joining us. And I'm going to give some announcement for the some of the next speakers. So at the end of this month, in July 29, will be another Pittsburgh Mafia, Dr. Kitty Ukanot, and she is actually a famous pediatric ENT doctor practicing in Bangkok, and so she will talk about the artificial intelligence model to interpret the findings of autoendoscopic examinations of otitis media in children. So we are not only have topics like all in head and neck, but we also cover some others. So I hope all the participants today could also log in July 29th and to listen to Kitty's lecture. And thank you again for all the participants, and especially to Professor Nakayama. And really look forward to meeting you in person in August, in September, maybe, and especially in November. And thank you again, Professor Nakayama. Thank you. Bye bye. That's a good. Thank you. So you were both invited to the Taiwanese ENT Society. So I think we could have some drinks together. All right.
Yes.
Looking forward to it, yes.
Looking forward.
Yeah.
Bye.
So,
Bye,
thank you.
everyone.
Thank you.
Bye,
Bye.
Peter. Bye, Meijin.
Bye. Thank you.
Bye.
Bye. Bye.
Morning.
Bye, Melinda.
Bye.
You want to sing together, Melinda? Huh?
I'm waiting for you, Prof. Sheng-Po.
No. I'm not singing. All right. Bye now. Have a good
Bye.
day.
Bye, Prof.
Thank you very much.
Thank you.